Hey, are you guys able to see the full presentation view? All right. I'm Melissa Jenkins. I am one of the infectious disease physicians at Metro Health. And I was asked to talk about what happens when someone has a partner who is HIV positive and they are negative, and what that means for the person. So I'm excited to share a little bit of knowledge and have a great discussion with you all today. Oh, I lost things when I clicked on the recording, so let me get it back. Okay. So we have two objectives that I'd like to cover today. The first is to discuss the meaning of U equals U and the implications for HIV positive persons and their partners. And the second is to discuss two options for chemo prevention for HIV for patients who are negative. We call that pre-exposure prophylaxis or PrEP. So there was really a big paradigm shift in HIV prevention maybe 10 or 15 years ago. Scientific advancements showed that people who have HIV are much less able to transmit HIV if their viral load was low, and that transmission was really related to the viral load. So there came about this idea of treatment as prevention. In the past, we used to wait until someone's T cells came down and became low before we started on treatment. But we began to see that the earlier we did treatment, the less likely the person was able to transmit HIV. So treatment really became a method of prevention. And we saw a shift in the guidelines towards treatment as soon as possible. The standard of care now is rapid start HIV antiretroviral treatment, where patients get started on medicine within 24 hours, or if not 24 hours, at least 7 days after their diagnosis. There's also been a lot of advancements in the area of pre-exposure prophylaxis, or things that people can do if they're at high risk, but before they become exposed to HIV. There's also been a lot of new formulations and delivery mechanisms in development: vaginal rings, injectable medications, vaginal films or implants to help prevent HIV. And there's been a renewed interest in post-exposure prophylaxis, or things that we can do after someone has had an HIV exposure. The CDC came out in 2014 and made an announcement that said that there were other ways to have protected sex besides using a condom, and that condomless sex wasn't necessarily analogous to unprotected sex. Mainly talking about these various methods we have that can decrease someone's risk for HIV other than just simply using condoms. And then finally, we learned about the importance of the social determinants of health on the role in HIV transmission. So what is U equals U? This has really been a game changer in HIV, both for patients and for providers. U equals U says that any person who is HIV positive or diagnosed with AIDS, who's on antiretroviral therapy, and who remains virally suppressed for at least 6 months cannot sexually transmit HIV. That means when someone's undetectable, they're untransmittable, or U equals U. Some of the data where this came from is summarized in this graphic here. This shows the number of new HIV infections per 100 person years in heterosexual couples where one person is HIV positive and the other is negative. And you can see that the chance of transmission is a lot higher when someone's viral load is above 50,000. If they get to a lower viral load, it doesn't even have to be undetectable, but just below 3,500, the risk of transmission is much, much lower. There were two large studies that were done that really made U equals U become possible. The first was HPTN 052, which was a prevention study. And they looked at 1,700 HIV serodiscordant couples and compared the effect of starting the positive partner on antiretroviral therapy immediately versus delaying ART. And what does that do to the risk of transmission to the HIV negative partner? And starting someone on early ART was associated with a 93% lower risk of linked partner infection. The second study was the partner study, and this study recruited HIV serodiscordant couples. Nearly 40% of the couples were gay, and the couples had condomless sex without any chemo prevention, either pre-exposure or post-exposure prophylaxis. The HIV positive partner was on ART with an undetectable viral load. And when they did an analysis after 2 years, there were no linked new infections. And based on the results of these two studies, the director of the NIH, Dr. Fauci, who we all know for other reasons now, came out with a statement that was very forward thinking at the time. It's rare that a government agency makes such a strong statement, but he said that these studies make it crystal clear that when an HIV infected person takes ART that keeps the viral suppressed, the treatment is highly effective at preventing sexual transmission of HIV to an uninfected partner. And the risk to their partners is exceedingly low. And although he referenced heterosexual relationships in this study, we have the later partner data that also supports that this is the case in non-heterosexual partnerships. So it's great news if someone's partner is undetectable. They can be reassured that the risk of transmission is very low. But what if someone doesn't have a partner who's undetectable, or if they have multiple partners and they don't know the status of those partners and may be at higher risk for HIV? We actually do have some opportunities for them. Pre-exposure prophylaxis is medication that's taken prior to exposure, hence the pre-exposure, to prevent the acquisition of HIV. And it comes in two forms that we'll talk about. There's a pill that one can take, and there's also a long-acting injectable available now. So a little bit about the basics of PrEP. These are medications that someone who's HIV negative takes to prevent infection before exposure. The first one to be approved was Truvada, which is a combination of tenofovir and emtricitabine, and that was approved in 2012 for PrEP. It's one pill daily, and any prescribing provider can prescribe and manage pre-exposure prophylaxis. Although we have a PrEP clinic at Metro, it can be prescribed by any primary care doctor who sees a high-risk patient. There were two other medications that have been approved. Descovy is a newer version of Truvada, which has the same two medicines, just a different isomer of tenofovir, and it was also shown in studies to be effective for PrEP. And both of those are more than 90% effective when taken daily. It takes about 20 days for women to become protected because of the pharmacokinetics and the integration into the genital system. It just takes a little longer for vaginal protection than it does for rectal protection, which is about after 7 days of therapy. So we talked about Truvada and Descovy as options. In addition to daily dosing, there are also ways that patients can take it kind of on demand. We'll talk about that in a minute. Some people call it the pill in the pocket approach or on-demand dosing. So if someone's only having intermittent exposures, they don't have to necessarily take it every day to have effectiveness. The newest kid on the block is cabotegravir or Apretude, which is an injectable long-acting antiretroviral that's given by injection every 2 months in the clinic. And those are the companies that make them, only relevant because there are patient assistance programs available from the manufacturers. And that is a way that patients without insurance can access the medication. So the event-based regimen that I was talking about is available only for Truvada or Descovy, and both of these are 99% effective. Patients may have side effects from those. There's a little bit of a startup phenomenon or getting used to the medicine when you first start taking it. There may be nausea or other side effects like headache. Usually these get better the longer someone is on treatment. There are some longer term side effects of Truvada on the kidneys and on the bones that are not problems with the newer version, the Descovy. The different isomer does not have effects on the kidneys or bones. The downside of Apretude, it is an injection and it is gluteal. It's can cause a little bit of an injection site reaction for a few days after the injection. There's a version of this that's also used for therapy that has another intramuscular injection along with it, and that other one is a lot more painful than the cabotegravir. And regardless of which drug you choose, the drug is not the only part of pre-exposure prophylaxis. It has to include also regular follow-up for serial HIV testing and STI testing. None of these pre-exposure medications protect against other STIs. So it's important to counsel patients that they should still use condoms to protect against other things. Only Descovy or only Truvada has been approved for receptive vaginal sex. They have not done the studies for Descovy yet. If you talk about effectiveness, there's been a lot of clinical trials that have looked at the effectiveness of daily. The best studied one is the Truvada or TDF and emtricitabine. And the decrease in risks are shown here, and it's pretty significant. In women, they really found a strong correlation between adherence to the medication and the efficacy of it. So the failures were shown to have low levels of tenofovir in the bloodstream and probably had less than perfect adherence. And it seems like this isn't as much of a problem in men who have sex with men, again, because of the pharmacokinetics of where the drug concentrates in the mucosa. This is the intermittent dosing for PrEP with Truvada. It's a 2-1-1 schedule. So 2 pills for 24 to 2 hours before sex, 1 pill 24 hours after. If you don't have any more episodes of intercourse, then there's a third pill 2 days or another 24 hours after the second pill. If there's ongoing risk, you continue taking the pills and then a final one 24 hours after the last exposure. We already talked a little bit about the side effects of oral PrEP, nausea, headaches, loss of appetite, weight loss, vomiting, rash. They're pretty low risk. You can see in the graphic on the right that it's about 2 to 5%, which I think is pretty similar to placebo, to be honest. And then in rare cases, tenofovir can be a cause of Fanconi syndrome, and there can be some weight gain with the newer form of tenofovir that's found in Descovy. So the injection, usually we start people out with an oral lead-in to make sure that they are going to tolerate it. So it's an oral cabotegravir that they take for 28 days. And then at month 2 and month 3, there's an injection, and then every 2 months after that. There is a little bit of a dosing window. Patients can get it 7 days before or after the target date. So unfortunately, we aren't meeting the goals of ending the HIV epidemic that have been set forth. We're lagging a little behind. The priority populations where we're still seeing a lot of new HIV cases are in men who have sex with men, especially men of color, and transgender patients. But these are also some other priority populations where you may want to consider pre-exposure prophylaxis. When someone is on pre-exposure prophylaxis, these are the tests that you will want to do both at baseline and then at follow-up. It's really important to do HIV testing every 3 months. You want to be able, number one, to detect a baseline infection. You wouldn't want to start someone on an incomplete regimen for HIV if they already have it. And also it's not 100% successful. So HIV testing serially is important. And then STI testing, baseline HBV testing is recommended because they both have HBV activity, and you want to know if someone has Hep B before you start them. Let me clarify, both Descovy and Truvada have Hep B activity. Cabotegravir, or the injection, does not. And then baseline renal function because of the effects of tenofovir on the kidney. At each follow-up visit, in addition to the testing, you want to reassess their adherence, their side effects, their risk behavior. Maybe they're now in a stable relationship with an HIV negative person or someone who's undetectable, and the risk-benefit ratio for that patient has changed. You can assess whether it might be time to come off PrEP. They can always go back on it later if they become at risk again. So how to get PrEP? It is pretty costly, but there are other ways to get it besides insurance. The first thing one needs is a prescription from a provider. As I mentioned, there's no restrictions on who can prescribe PrEP. Any prescribing physician or nurse practitioner is able to write for it. It is covered by Medicaid, and most insurance also covers it because it does have a Preventive Services Task Force rank of A. Gilead has patient assistance programs and copay cards available for both Truvada and Descovy. There's also a program called Prevention Assistance Program Interventions, or PAPI, that can provide specifically PrEP medications. At Metro, we also have financial assistance and can assist with any prior authorizations. I realize that not everybody has those resources. We also have an awesome PrEP navigator at Metro named Akeem Rollins. He takes calls from all over Northeastern Ohio for people seeking to get on PrEP and can hook them up with a provider in the area, whether it's at Metro or somewhere else, and can also help people go through the patient assistance process to get on drug and access it. So he's a great resource and would love hearing from you or your patients if someone is interested in getting on PrEP. So special thanks to Akeem and Ann Avery, whose slides I totally plagiarized with their permission. But at this point, I'll stop and can take any questions.